Hi, I'm Brad Power, and this is the Cancer Patient Lab. Today, we're honored to have Stephen Merlin with us. He's an example of a very engaged patient, and you'll hear his story and how he managed to get actively involved in his care. And probably he's with us here today in a relatively healthy state because of the interventions that he did, the things that he put his finger on the scale at various points in his journey to make certain treatment decisions. Um, Three housekeeping things to cover before we get started. The first is this is for information purposes only. We like to arm patients and caregivers with information they can take to their medical team. This is not medical advice. Uh, Second, this will be made public. Everything you say can and will be used against you in a court of law. So if you're concerned about your image, your name, or anything you might say becoming public, you can turn off your screen, change your name, and don't say anything. And finally, we are a nonprofit, volunteer-led nonprofit, and would welcome any donations that you might make to our community. You can do that through our website where there's a donate button. And with that, I'll turn it over to Stephen. Again, he's an exceptional patient, and he has an amazing story to tell in his journey around pancreatic cancer.
Thank you, Rick. Brad, I'm happy to be here, and thanks to all of you that are on today. So I'll give you a brief executive summary of my background. I initially trained as a medical technologist from 1979 to 1980 in a local medical center. And my first exposure to pancreatic cancer was sitting in the patient grand rounds and listening to the case presentations and thinking to myself, there's one cancer I never want to have. And back in 1979, there were really no drugs for it. So basically, if you had a low stage diagnosis and eligible for the Whipple procedure, you had the best chances of survival, and still was pretty low. Um, After I became a medical technologist, I quickly transitioned into clinical research, and I began my career at the National Institutes of Health. And at one point, I was working on a collaborative study with Dr. Anthony Fauci. And I started off in immunology. And then I started to get into cancer research. In 2012, I was working in the Department of Pathology at Weill Cornell Medical College in New York City when I started to get the initial symptoms of pancreatic cancer. After 5 days of having darkened urine, I decided to go see my primary care physician, who pronounced me a picture of health. I did my vitals, everything was fine. And he said, if I didn't feel better, come back at the end of the week. Well, I didn't feel any better. I didn't feel any worse. So I went back and I said, there's something really wrong here. And having been a med tech, I made some suggestions on let's do liver function tests. I was thinking back to, I was at age 55 at the time. My father at age 55 had gallbladder disease. And so from the presentation of symptoms, I thought maybe this is related to having gallstones. So we did liver function tests and a few other things. And that led to my getting a sonogram. And when the sonogram showed that there was no gallstones or any sludge in the bile duct, my primary care physician cut the losses, called his colleague at Weill Cornell Medical College where I was working and asked, could he send me over and have a look at me? And so he told me just head right down to his clinic. I got there. His colleague was waiting for me, and we started to do the testing. Uh, so I think probably all of us were brought up where you're told, listen to what the doctor has to say. And usually we don't question anything. And I was the same way. So I got my diagnosis and I listened to what the proposed treatments were going to be, and everything seemed fine for that. I had a Whipple very quickly. I was diagnosed on Friday at 1:30 in the afternoon. I signed all the paperwork, and then the surgeon, when I asked him, by the way, when do you want to do the surgery? And I thought he would say 7 to 10 days from that point. And he said, tomorrow morning, we'll wheel you in at 6:30. And I said, wait a minute, isn't today Friday? you're going to give up a round of golf on a beautiful June Saturday. And he told me that I had a very aggressive form of it. I had a rare type of pancreatic cancer. It was called acinar cell carcinoma, about 1% get that. So we put it off until the following Monday when I had the surgery. A week after surgery, they did a post-surgery CT scan and found that I didn't have a blockage in my intestine because I wasn't able to have a bowel movement, and that's the purpose why they did that CT scan. But they never told me that they found metastatic disease in my liver. So the tumor board meets, and the tumor board decides that they're going to put me on palliative treatment because there was no point in doing curative treatment. I had no idea that I was stage 4 at this point, and I just assumed that everything was fine. The doctor is doing what would be in my best interest. 3 months later, the next scan is done. The results are released before the doctor saw it. So this was at a time before they would automatically release your results to your patient portal. So on my way to get chemo that morning, when I saw the results and let out a gasp on the train, and when I got to the clinic and saw my oncologist, I said, please don't preface your remarks with "I'm sorry." And he looks at me kind of strangely and says, what are you talking about? And I showed him my iPhone with the results. So then he said, well, he was trying to sugarcoat it why they didn't put me on the more aggressive FOLFIRINOX treatment, which is 4 agents that they give you that's very harsh. And that's used in the curative setting. So that's when I got my voice and started to advocate for myself. And I said, look, we did plan B first instead of A. How about we do plan A? I've got nothing to lose here. All my affairs are in order. I understand the repercussions that I could get from doing this extensive chemotherapy and at a high dosage, but I'm willing to take that. I have nothing to lose. So thankfully, he agreed. They watched me very carefully, and I tolerated the first dose fine. So I went through 6 and was doing well. And then to give my oncologist credit, he decided, since I was going to be on this for the long term, seeing that I was handling it well, he took away 2 of the agents, one that causes the peripheral neuropathy in your feet and your hands, and the other one that kind of is very harsh on your GI tract. So then I had 6 resting cycles of just the backbone agent called 5-fluorouracil and a vitamin called leucovorin. It's a reduced form of folinic acid. I did 6 of those. That gave the peripheral nerves a rest. Then again, for the following 6, I went on full dose, and we kept doing this. And so they were watching me very carefully. They would always ask how I felt. And compared to the alternative, being dead, I'd always say, I feel great, even though sometimes I didn't. But I was just so afraid that they would say, well, maybe we should take a break here. Well, I got through it with no breaks. I did 46 cycles every 15 days for 24 months. And I hung in there. And then during this time, I started to look for clinical trials. So I remembered after coming out of my Whipple surgery and how bad pancreatic cancer is, that it was probably going to take a clinical trial to make a difference here. So that's when I started looking on my own. And at that point, I was searching blindly. I had, no idea what to look for. So I would just go on clinicaltrials.gov website, put in a parameter field for pancreatic cancer and then metastatic, and see what would come up. And you're reading through tens and tens of clinical trials there, trying to find something that might be appropriate. When I had a CT scan after the first 6 cycles of FOLFIRINOX and was doing extremely well, I had double the amount of shrinkage that they see in most people. I had 60% shrinkage. They considered 30% after 3 months really well. I was asked what was the history of my family as in regards to cancer. And I had already told the surgeon that months before. So I went over it again, that every female on the maternal side of my family had breast cancer. And then I was asked, was I ever checked for any kind of genetic mutations? And I said, no, I was only advised that because my mother had colon cancer in addition to breast cancer, that I should start screening for colon cancer earlier than what is normally prescribed, which I did. But nobody ever mentioned anything about BRCA mutations. I did know that my mother's first cousin and her two daughters had been screened for the BRCA mutation, and they were found to be BRCA2 positive. And I made mention of that to my oncologist. So that triggered me getting tested for the BRCA2 mutation and being positive for that. I immediately called my brother and said that you need to go get tested, genetic testing done to see if you have a germline BRCA mutation. And sure enough, he has one, but he's healthy. Uh, so now that I knew that I had a BRCA2 mutation, that gave me an idea of what to look for in clinical trials. I met with a geneticist to inform me that there were clinical trials that targeted the BRCA mutations and to look for PARP inhibitors. So I started to focus my uh, trial search on looking for PARP inhibitors. And it took me 14 months. I was very persistent. I would find trials that were close, but not quite a good match. And so I just hung in there and I would look about every week. And I was on the site of the American Society of Clinical Oncology. They were having their meeting, which they usually do at the end of May, first week of June. I remember going on there on a Saturday to see if there was anything posted on recent advances in pancreatic cancer, and there was nothing. I got up Sunday morning, did the same thing, and there it was, an abstract posted that was presented by a group at the University of Pennsylvania mentioning about a pilot study on two patients where they used a PARP inhibitor. And within 6 months, there was really dramatic results. And it gave a hint that they were going to open a clinical trial using a PARP inhibitor. So I on Monday, I called the National Cancer Institute because I had looked on clinicaltrials.gov for this trial and I couldn't find it. They looked for me, they couldn't find it. So then I called Pancreatic Cancer Action Network, which is a patient advocacy group, and they have an extensive database. They couldn't find it as well. So at that point, I told the Pancreatic Cancer Action Network that I had the contact information of the lead author of the abstract that was presented. I had her email and her phone number. Could they contact her and let them know that I was interested in this potential trial? I got a call back from PanCan about 20 minutes later, and they said they got in touch with people at the University of Pennsylvania. They gave me the name, phone number, and email of a clinical trial nurse coordinator. And I called her up and I told her who I was and the trial I was interested in. And she's drawing a blank. She said, no, I have no idea that we're doing any kind of clinical trials for pancreatic cancer. We're doing this on women with ovarian and breast cancer with BRCA mutations. And I said, gee, that's strange. PanCan called the UPenn. They got connected to a clinical trials department there. That's how I got your name and your phone number. Okay, I'll call PanCan back. So this is where persistence and perseverance really comes in when you're doing self-advocacy. And I asked PanCan if they would call the principal investigator, supposedly, of this trial, which they did. And I got a call back from the principal investigator a couple of hours later, who explained to me that they couldn't breathe the word of this potential trial to anybody outside of the authors of that abstract. So she couldn't even tell her clinical trial nurse coordinator, and that's why that person didn't know. So I went down, I had the interview, I had all of my records all together. So, as part of self advocacy, what I was doing from the very beginning, I was always very organized. And remember, back in 2012, things were just starting to transition to patient portals. So, what I would do at each of my visits and exams was I would ask for printouts of the exam notes, and I would get also the test results from blood chemistry and anything else I did. Whenever I went for a CT exam, they would give you a complimentary copy of your CT scan on a CD disc. So I would always get that. I would usually they would give me two copies. I would keep one in my own archive at home here, and I could always burn copies from that on my computer if I needed additional ones. So I had notebooks. They were organized into sections where I had all of my lab work. I had my radiology interpretations, and anything else that I could find things very quickly. And I was also scanning them onto the hard drive of my computer so I could easily burn it onto a disk. And when I found this clinical trial, I was able to put all the information on a CD and overnight it down to the University of Pennsylvania. So they had it the next day. Um, some of the things I did in self-advocacy was a lot of my own research. So I would do searches on the internet. Um, we all know that there's a lot of things which are standard of care, but sometimes it might take something beyond standard of care to try to get a better outcome. And so for, each of the different cancers, they'll have a standard protocol of things that they use, but there may be other techniques out there that are currently in use for another cancer, and they might be able to be used for another type of cancer. And that's very true with pancreatic cancers, where techniques that are being used for other solid tumors, such as colorectal cancers, liver cancers, can be ported over to pancreatic. So I started trying to find out what those things were and reading up on them. And now using things like artificial intelligence, chat GPT, there's another good one called openevidence.com. This is one that's a consortium of a number of leading medical institutions and some pharma and biopharma companies that are sponsoring it. That's really good for anything that has to do with clinical medicine. And so openevidence.com is another one that I use. And I'll put a query out there. And so it's important in the how you phrase things for the type of information that you're going to get back. So the more information you can put in there and being clear and concise, the better the information that's generated that you can work with. So I was using this to find out about different types of other treatments that are used that are approved in other cancers, but they might not yet be FDA approved for use in pancreatic cancer, but can be used in that. And that really helped. So I did use pretty much standard of care, but where we went off of standard of care was I went well beyond the 12 cycles that they normally use for the chemo protocol I was on called FOLFIRINOX. And that clearly made a difference. Another thing that I advocated for is that over time, as you progress and you have no evidence of the disease, they start to cut back on the number of surveillance scans that you do. Well, with pancreatic cancer being so recalcitrant, I opted to do more than just one a year. And so I had requested that we do it every 6 months. That way, if something occurred, say you were doing just yearly, and a month later you started to get recurrence, well, you wouldn't know for a year. And with pancreatic cancer, it could really take hold, and it's quite hard to eradicate once it comes back. It's usually more aggressive. So I felt that if I did it in an interval of 6 months, I'd be in a little bit better position to try to then treat it. And so that was fine. I was told we could do 6 months. There's been no issues with private insurance. And since then, I've transitioned to Medicare. I've had no problems with Medicare paying for both of those. I frequently go for multiple opinions. I've never had any issues when I went for more than one opinion. It's always been paid for, no questions asked. So there's a lot of things there. Don't assume that, it can't be done. Always ask and find out. And usually the answer is that you're allowed to do that. So those were some of the advocacy things that I did. And then besides self-advocacy, I've been involved with government advocacy, trying to make things better for patients, particularly high cost of medications and the financial toxicity that occurs from costs of these things. Um, I try to make people aware that there's a lot of help out there through organizations and some of these pharmaceutical companies where the cost may be prohibitively expensive and you may have a very high copay. There's patient assistance programs from all the different pharmaceutical companies, which will help you in getting a discount card for a very low copay, or in some cases, you'll get the product for free, so you won't have to pay for it. Some other things is that sometimes people are reluctant about doing clinical trials. One of the barriers is, well, it's too far, or they think it's going to impact. I've got to work. I need to make a living here, get a salary. I'm getting my health insurance through that. And so they either want to take a clinical trial that's very close by or not do one. And so what I tell those people is that number one, you're more valuable to your employer alive than dead. And most employers will understand the situation you're in. My employer did. I was able to take the time off for that. And I wasn't going to cut my chances of finding a successful trial by limiting it to a small geographic area, say within 50 or 100 miles. My goal was to find a clinical trial and qualify for it, and then worry about the logistics of how to get there. So one thing about most clinical trials is you're reimbursed for your mileage, or if you have to buy a train ticket, your parking, your tolls. So that's covered. In clinical trials where it may require airfare to get there, trials that are done at the National Cancer Institute or the National Institutes of Health, they handle all the logistics of travel. They pay for your airfare. If you have to stay over, that's all covered. So there's no financial issues involved with that. But some of the other trials, say you're going to a medical center, you're on the East Coast and you find the trial on the West Coast, there are some organizations, one of which is called Corporate Air Angels. And there's several like that organization. They're nonprofits. They get donations, private donations, but also they have aircraft that are provided by, it's on a space available situation. So they'll provide a seat for both a patient and one caregiver. And this organization will handle logistics, finding a corporate aircraft that's going from a corporate air park near you. If you can't get there on your own, they'll take care of having an Uber, Lyft, or a taxi get you there. They fly you to the destination. They handle the ground transportation to where you're going to be treated. And then if they can't get you back on the same day on a returning aircraft, they'll make arrangements to put you up at a hotel and so on. So there's absolutely no financial risk to the patient in doing this. It's just the time that's involved. So these are kinds of things that I try to do. It's part of my advocacy to make people aware that there's a lot of things out there in helping you to get a better outcome. And so with that, I think if anybody wants to ask questions, I'm ready to go.
Thank you, Stephen. Yeah, we use the raise hand feature. David's there already. And then I'll be monitoring the chat if people can also substitute comments or questions through the chat. I'll just a couple of definitional things, Stephen. For those who don't know, can you describe the Whipple surgery? That was like step one in the standard treatment for your diagnosis.
Right. So the Whipple procedure is one of the most difficult surgical procedures to do. And if you're of stage 3 or lower, they're able to do that. So usually it involves when you have a tumor on the head of your pancreas, they can do the Whipple procedure. The procedure was developed in 1935, and it has a pretty good outcome. And what they do is you're opened up underneath your rib cage, or they can do a midline vertical line down here. And what they do is they resect the head of your pancreas. They take out part of the bile duct. They take out your gallbladder. They remove the duodenum and about 2.5 inches of your jejunum and the bottom portion of your stomach, although there is a pylorus preserving procedure where they keep the pylorus valve. And then they would attach the bottom of the stomach to a part of the jejunum along with sewing on the remnant part of your pancreas, which would be the body and tail. And then basically you're good as new. So some people may need to take digestive enzymes after having the Whipple because in the head of the pancreas is the cells which produce and secrete your digestive enzymes, amylase, lipase, and protease. Um, Sometimes you can have atrophy of the remaining part of your pancreas, and that could lead to becoming diabetic. So that could happen about 30 to 40%. I came through the Whipple okay. I didn't have any kind of issues afterwards, such as leakages where I had to have drains. I do take digestive enzymes, and the dose varies depending on the type of meal that I have. So generally, when you have meals that have a lot of dietary fat, that could be a problem for some. And especially that you don't have a gallbladder where you have a reserve of bile salts to emulsify the fats in your diet. So if I stick to low fat, non-fat diet, I'm okay. I can get by with little to no creon. But if I want to eat as I did before I ever was diagnosed, which I do, if I want to have a nice filet mignon or something like that, I'll take the creon. And so basically, I'm back to normal. I'm a 12.5 year survivor of stage 4. Um, I was told after the 2 years of the heavy chemo that I was no evidence of disease. And I never did ask, but about 10 years out, I was at a meeting when a surgeon at Columbia University was doing a presentation and knew that I was in the audience and was mentioning that there are now accounts of people that have done FOLFIRINOX treatment and have achieved cure and mentioned me by name. And I was like totally shocked. I had no idea that was coming. And I've heard now from a number of other pancreatic cancer specialists around the country, they consider me cured and they credit the amount of FOLFIRINOX, particularly the oxaliplatin component of it that I had for doing that. So I do continue with the scanning. I also have what's called ctDNA, which is the cellular tumor DNA that's made specific for each patient. It's very sensitive. That test has been done since 2014. I have it done every 90 days and it shows zero. They do the carbohydrate antigen 19-9 test on me, although my tumor type never secreted that. But should I get another primary pancreatic cancer, it could secrete CA 19-9. So that's the reason why we do that. And then, as I mentioned, I go twice a year for the scans, which I have CT scans. Or actually, I do MRI now. After 7 years, I switched from CT to MRI because of the potential accumulated effects of the radiation and getting secondary cancers. So we do MRI.
Just one more quick thing following up on that. When you were diagnosed, I think we talked about this before we started recording. When you were initially diagnosed, what's the success rate of the Whipple procedure and the standard of care? What were you looking at?
Right. So the statistics now is that about 80% that have a Whipple and finish their treatment within 24 months, there's a recurrence. So it's only about 20% that don't get a recurrence. And it's like, you don't know who's going to get it. So knowing that, when I went into this and I was thinking, gee, we're doing the same thing over and over, and we're not getting really any better at it here. Maybe if we try something different. So that was the impetus for me to say, wait, we're only doing 12 cycles and we're seeing 8% recidivism rate. Maybe I'll try going more than 12 to see what happens. And, being that I came from a background in clinical research, I was always inquisitive, and a lot of people that I mentor know my background, and they would ask me, well, why did they pick 12 cycles of FOLFIRINOX? And I started doing searches on the internet, and I couldn't find that answer. I was really curious. And I had the opportunity to talk with one of the pioneers that did the early clinical trials on FOLFIRINOX. And I asked that question, and he was wondering how I knew to ask that. And I told him about my background, and people were asking me. And he said, well, most likely it was a working group of oncologists through the American Society of Clinical Oncology that were pancreatic specialists. And they were asked the question, how many cycles of FOLFIRINOX do you think your average patient could tolerate in order to achieve no evidence of the disease? And by consensus, the number 12 was pulled out of the air. And so knowing that, the goal is to get you to no evidence of disease. Well, what is no evidence of disease specifically? That is that using conventional imaging of either CT, an MRI, or a PET scan, that they can't see disease. So you have to realize that those instrumentations have a level of sensitivity. There's a threshold that if it's not exceeded, won't see anything that's too small. So you can have what's micrometastatic disease, or what's called minimal residual disease, that which remains after you go through treatment, that's there. It could be quiescent. And as long as your immune system is strong and robust, it can withstand any kind of challenges. But if it weakens, all bets are off. And now anything that was quiescent could come back, and now you have the problem with having to deal with recurrence. So that was my impetus of, let's go further beyond the 12. And nobody knew, well, how many would result in cure or not. So the reason why we stopped at 46 was because at that point, the clinical trial that I found came on. The response to my tumor was slowing, and it may have been because there was nothing left. All they could see, I had 6 large tumors scattered throughout my pancreas, and then there were others that were classified as TNTC, too numerous to count. So they were all over. A lot of them were below 1 centimeter. My largest tumors, one was 4.2 by 3.8 centimeters, and there was another one almost as large, sitting right on top of the hepatobiliary tree. So that made it inoperable. I was looking at other types of techniques, such as radio frequency ablation. Now they have what's called nanoknife or irreversible electroporation. That wasn't available 12 years ago when I was around, or I would have considered that. So at that point, my oncologist said, okay, it looks like you're on the waning side of the chemo. Now's the time to switch and go into the clinical trial. So the purpose of the clinical trial that I was in, using a PARP inhibitor, is for maintenance monotherapy. For people that have BRCA mutations, there's a slightly increased risk of developing a new primary cancer. For males with BRCA mutations, it's pancreatic male breast cancer and prostate cancer. For women, it's ovarian, pancreatic, and there's one other one, breast cancer, ovarian, and pancreatic for women. So knowing that, I went on this PARP inhibitor. The trial was for 2 years. I was the first U.S. patient on it. I was on it the longest. I had a complete response to it, and I'm still on it 10 years and 3 months later. So they don't know what to do with me at this point, whether to stay on or not, because there's nobody ahead of me to know what happens if you go off it. And so it was left up to me, and I figured, well, being that I have an increased risk and there was no issues with suppressing my bone marrow, where they found in women that were treated with carboplatin, which is a type of platin agent. I had oxaliplatin, which is not quite as harsh. Some of those women went on to develop myelodysplasia syndrome, which led to acute myelogenous leukemia, which could be fatal. So, of course, that was a concern of mine. I did have a bone marrow aspirate done, found that there was no effect. And usually that happens earlier in your course of treatment with PARP inhibitors. So I did a lot of research into that. Everything was fine. So I've stayed on it. Hopefully, it's giving me protection against developing prostate cancer and male breast cancer, as well as a recurrence of pancreatic.
Thank you. David Plunkett has a question.
Hi,
Hi,
David.
Stephen. Question is, when you did the genetic testing, how did you arrange for that? And is there anything better available now?
Great. So, good question. With me, when I was telling my oncologist the history of the family with breast cancer, and asked if I had ever had genetic testing and said no. He goes, okay, I'm going to send you over to the geneticist at Weill Cornell. And I met both with the geneticist and first, actually, I met with the genetics counselor. So she did a cheek swabbing and they extracted the DNA from that and they did the family pedigree. So I had a pretty good idea of all the people in the family on both the maternal and paternal side, and going way, way back to great grandparents and distant cousins and so on. So, we could see what the history of cancer was there. But for people that have a history of any kind of cancers in the family, and especially if it's same type of cancer, you can either go through your primary care physician and say, hey, there's a history of cancer in here, especially in close blood relatives, and they can refer to you to a geneticist, or you could call up the genetics department in a large medical center. So generally, if it's a National Cancer Institute Center of Excellence or a comprehensive cancer center, they will likely have a genetics department. And you call them up and you tell them that there's history of family, history of cancer in the family, and that you're concerned, and you're near an age where a member of the family had developed the cancer, that you'd like to go in for testing. And it's covered by insurance, so there's no issues there. So they can.
Did we lose him?
Yeah.
Uh-oh.
There he's back.
Yep. Am I there? Yeah.
Yeah, you're back.
Okay. And so they could do it on those three things, and it generally takes about 2 weeks. Catch log.
Brad, you might suggest he turn off his video.
Okay. He was fine for the first, 40 minutes.
Just like cancer, I was fine for the first 40 years. So.
Somebody turned on the microwave to heat up a sandwich.
Oh.
Can you tell if he's still connected? Or is he just frozen?
So I find Zoom's pretty good. It reestablishes contact. So I think if we hold here, he'll come back. Oh, he disappeared. So he's going to log back in, presumably.
While we're waiting, maybe I missed it. Did he say he had his tumor tissue checked for mutations? Do we know?
I think so, in order to identify the BRCA mutation and in order, we can ask him, but I think to get the BRCA mutation and the PARP inhibitors, that at that point,
he definitely did. He's had loads and loads of NGS and similar. But ask him about it and he'll tell you. But he's had a lot of as far as I recall, he's done a lot of analysis on his tumor.
Yeah. And did he say which PARP inhibitor he's taking?
No, he did not say.
But it doesn't, at this point, although there are trials out there. In fact, I got a buddy in Sydney, Australia, a doc who's just going into one for a new part. But the existing parts don't seem to make it much of a difference. That they are they differ in terms of their potency, so the size of the dose changes, but in terms of the actual effect, we don't seem to think that whether you're taking
He's back.
Yeah.
rucaparib or
I went on
olaparib,
to
it makes a difference.
here, so I heard the questions. The PARP inhibitor I'm taking is called Rubraca. It was known as rucaparib. They never applied for FDA approval on that because AstraZeneca had the market share with Lynparza, also known as olaparib. So rucaparib is used in women with ovarian cancer, and it also got approval in prostate cancer. And it has a very good safety profile. I have really no side effects from it other than anemia. And so I did one dose reduction, and that's how we manage it. About every 6 to 7 months, I'll go on a short pause, and all of my hematology parameters bounce back up into the normal range.
So Stephen, you're on twice here and we're getting a little reverb.
Okay, I'm going to cut the other one off here. Hang on. Okay, how's that?
Good, no reverb.
Okay.
Yeah, so
the other question I heard was, did I have the somatic testing done? So that was done on tissue sample that had been archived after the surgery, and nothing came up other than I have just BRCA2 mutations. There were no other mutations that were the driver of my cancer.
And this is all DNA-seq, not RNA-seq, correct?
Right, correct.
And what kind of scans are you taking annually, or however often you do?
So now every 6 months I do MRIs. So for the first 7 years, I was doing CT with and without contrast. And then a number of oncologists were saying, 7 years, that's a lot of cumulative radiation. And I was concerned about getting secondary cancers, especially lung cancer from it. So they recommended switching over to MRI. So the problem with MRI is that you can't image lung tissue. So they could do low dose. At this point, the risk of getting lung cancer, I'm getting ctDNA done, I'm getting CA19-9 done. So we're just doing the MRIs. If anything is detected, then we could do a lung screening. But the risk right now at 12 and a half years out is pretty low.
Is that an MRI with gadolinium?
Yes. So of course there's, people raise the issues about cumulative gadolinium in the brain and so on. And I checked with the FDA. They're aware of these concerns and they're monitoring this, but so far there's been no pathologies associated with the gadolinium.
Roger, did you have any other questions?
I have so many questions,
Go.
but let me just ask a couple of them just quickly. So the test you get every 90 days is cfDNA. Is that Signatera?
No, I'm getting ctDNA. It's done by another company that it was in conjunction with the clinical trial that I was on. So I don't know the name of the company, but I met one of the principals of the company, and they're doing a study at the U of Penn, looking at patients and their ctDNA to see if there's any changes early on, trying to detect recurrence.
Okay. And, you know, it surprises me you're getting scans every 6 months, 10 years out. I thought the standard of care was they stop scanning you after 5 or 6 years and they go to 1 year scans, you know, at 3 years out.
Right.
How do you get so many scans?
I asked for it. And I said, you know, I know the high rate. I went through the hell of a Whipple and all of that chemo. And it's like, I'm not throwing caution to the wind. And if
Right.
science can learn anything from my participation in doing more of the scans and stuff, you know, I'm happy to be able to do that. So for me, it's, you know, no, it's not inconvenient for me to do the scans. I do them where I had worked at Weill Cornell, but all of my care now is through the University of Pennsylvania. So, you know, every 6 months I go into New York and I have the scans done.
You know, that's one of the surprising things about this. I had to negotiate my scans as well, like everything else, because they wanted to do fewer than I wanted them to do at first. But you would think, I don't know, very many people would think to even ask, you know.
Right.
The doctor says, gee, the insurance company says you should have this. How many people are going to go say, well, you know, I think I'd rather do something else.
Yeah.
Hey, last question. I have is you were stage 4, you said it was metastatic. Was it to your liver or
Yes. Yeah. Just in the liver.
just
So
the
I
liver?
was actually stage 4 when I had the Whipple and they didn't know it. So back in 2012, the resolution of CT was between 4 and 5 millimeters. Today it's down to 1.25. So I may have just been below the threshold of detection at that point. And 2 weeks later, from when I had the original diagnostic scan, is when the radiologist started to see hints that I likely had metastatic disease to the liver. So the tumor board, knowing that, put me on a very mild chemo called Gemzar or gemcitabine. And back in 2012, Abraxane was still in clinical trials, so it wasn't the combo drug yet. And basically, Gemzar was a little bit better than taking water. So with me, it turned out that I was one of the 10% in the population which doesn't make the enzyme to metabolize Gemzar. So it was never breaking it down, and I had no toxic effects to my malignant cells. And so I remember when they would ask me, how are you feeling? And I go, yeah, it feels like I'm doing water. You know, and now I could laugh at that because basically I was getting the same effect of drinking water. It had absolutely no effect. So the next time we had that CT scan, the tumors were significant in size and they were all over my liver. So it was lucky that I responded to the full Furanox.
Yeah.
You know, and the other reason why I still do 2 scans a year is that in 2018, they discovered that I had an interductal papillary mucinous neoplasm in a branch duct in the tail of my pancreas. So generally when they're in the branch duct, they're benign. And they have found another one, which is in the body of my pancreas, but it's also in a branch duct. And so for peace of mind, I go for surveillance. Every 6 months, we do an MRI, and I have that done at Memorial Sloan Kettering in New York. But all my scans I've always done at Weill Cornell. So I've kept that consistency of basically the same instrumentation and the same radiologists that are familiar with my scans. And I also make sure that I point out when they ask, what is the purpose of getting the scans? That, you know, I tell them it's long-term follow-up, having had metastatic disease to my liver, and also that I have interductal papillary mucinous neoplasms, so that they're focusing in on those 2 things when they're reading my scans.
One really quick one, if you don't mind, Brad, just the PARP inhibitors, I've heard that people develop resistance pretty quickly to those, but you've been on this for 10 years, it sounds like.
Yeah.
So you must not think so.
Right. Yeah. You know, a lot of the oncologists were surprised. I was at scientific meetings and they were talking about how PARP inhibitors generally 2 years and that was it, 3 maximum. Most people would get a resistance to it. And I walked up to the microphone and introduced myself, and I think at that time I had been on it for 8 years, and they were all really surprised. So there are people that are statistical outliers out there. I'm one of them. And I was on full dose of the rucaparib for 6 years until one day I noticed I was doing some really strenuous work and extremely fatigued. I got very lightheaded, started to get syncope, thought I was going to hit the ground. And I mentioned it to my oncologist. We did the hematology check. My hemoglobin went down to 7.1. It's like when you drop below 7, they give you a transfusion. That's how close I was. Walking up a flight of stairs was extremely debilitating. If I suddenly got up out of bed, I would get very lightheaded and almost pass out. So that's when I went on a 6-week break from it. Everything bounced back up. Another thing that PARP inhibitors do is they will give you a decrease in your estimated glomerular filtrate rate. So your eGFR will go down. You'll see your creatinine rise. And then first thing, a nephrologist will look and say, oh, you've got stage 3A kidney disease here. And they wanted to classify me as stage 3A. Well, it turned out when I took the short pause from the PARP inhibitor, my eGFR went back to normal. My creatinine dropped back down into normal. My hemoglobin, hematocrit, and red blood cell levels all increase. So it's just transient changes that I see when I'm on it long term. So we decided to manage me long term that we did 1 dose reduction, which originally I was at 1,200 milligrams. I went to 1,000. And now instead of doing another dose reduction, I just do pauses every 6 to 7 months. And I feel great again. So I just came off of a recent pause. I've been back on the PARP inhibitor for a week now. So I'm still feeling great. But slowly over the next 5 to 6 months, I'll start to feel it a little bit. And I'll usually stop before it gets really bad and take that short pause.
So I had go on.
Yeah, we have 4 more questions and we have 3 more minutes.
Okay.
So can we make these lightning round questions and answers,
Yeah.
please? Go ahead,
Okay.
Bill.
Yeah. So what are the genetic mutations you wind up having? Has anybody else, you have a unique signature. Has anyone else tried this medication on it? And they mentioned that this drug stops working. Maybe it has stopped working. Maybe basically you've had a complete response. That's my one question.
Right. So there are a couple of PARP inhibitors, Zejula, also known as niraparib, Lynparza, which is olaparib, and rucaparib. There's a few others, so they're working on next generation. And also the clinical research is focusing on trying to figure out how to prevent the resistance to PARP inhibitors.
Thank you.
Elaine, your question.
Have you been following the clinical trials at NIH for histotripsy on the pancreas? And do you know of any initial successes on that?
Yes, so I know in my area, NYU, and also Weill Cornell is doing histotripsy now. A number of places are coming online around the country. So there really isn't any long-term data yet on pancreatic cancer, but it's pretty much a non-invasive procedure and looks like a good alternative than going in there and having to do a resection of your liver. And how it compares to nano knife, I really don't know yet. So I'm waiting to hear more, and hopefully information will be forthcoming from these clinical trials to see how they compare head to head. It's
Thank
something
you.
I would definitely consider if I ever had a recurrence in the liver.
Thank you, Rick Davis.
Yeah, Steve, I'm just wondering if you've ever repeated your NGS, because in cancers like prostate and others, the somatic mutations can change over time. I don't want anybody to walk out of here thinking, oh, I should only get it one time. You have to keep monitoring.
Exactly. And so this was a question I had asked about how frequently should we do this. And so generally they said about every 4 to 5 years, there's many more new gene mutations discovered that it would make sense of that. So I don't have any more tumors that they could go in there and take a look. So, we just have to do it by blood tests to see what they can detect that way. So I've had it done 3 times now over the past 12 years.
Thank you. Ellen.
Yeah, hi. I put mine in writing as well, so I'm just going to go back and look at it. So one, I joined late. So Stephen, if you could, do you have PDAC or do you have the endocrine, or do you have a different kind of pancreatic cancer? I missed the beginning.
Right, good question. Yep. So primarily it's pancreatic acinar cell carcinoma, but it was a mixed tumor type. So I also had PDAC, but the vast majority was the acinar cell type, which is slightly better than PDAC.
Okay. And then the other thing I wanted to ask you about is what is your approach to lifestyle choices, especially with diet, exercise, that sort of thing? Do you just eat whatever the heck you want, or do you do anything special?
Yeah, great question. So I was always very health conscious since I was in high school when I started eating non-fat, low-fat foods. I did a lot of exercising, and at the time of my diagnosis, I was doing extensive bike riding for endurance. So I would do 50-mile segments as much as 4 times a week. So I was in great shape, my diet, everything else, but you can't do anything about genetics. So have I changed anything? No, I still maintain that healthy lifestyle. I do eat a little bit more red meat than I used to. And sometimes I'll add some chocolate cake, things like that, whereas I would pretty much avoid sugar up until I got ill. So I don't deprive myself. If I want something sweet, I don't worry about that, a bowl of ice cream, things like that. But otherwise, I maintain healthy diet and exercising. So I try to do at least 150 minutes of exercise per week. So it could be, 30 minutes a day. Sometimes I'll do a 3-mile or 4-mile walk, which will take me an hour, even in cold weather. If it's really inclement weather, I have a stationary bicycle, I'll do that. Or if I'm someplace where there's a multiple story building, I'll walk up the stairwell several times to do cardiovascular. I'm cheap. I don't go to the gym. I find all these free things that you can do, like free Stairmasters in a building.
Great. So out of respect for people's time, I think we should wrap, but I'd like to give you the final word, Stephen. What's your kind of summary or any closing message you'd like to share with us?
Right. So I would say you need to do your research and don't be afraid to speak up. If you find things, present that to your care team, have the information with you. Always write down things. I'm a big advocate of using the patient portal so that, during the course between my follow-up exams, I'll make notes and put it in there to make them aware of how I'm feeling so that they can then address it when I go there in case I forget it. So, always stay on top of things and stay attuned to your body. If something's not right, don't say, I'm going to wait and see if it goes away. If it hasn't cleared up within 5 days, go see your primary care specialist.